So today I'm going to talk about approach to rational test utilization. So a little bit of a switching of gears, moving from medications a little bit upstream onto lab test utilization before. So the objectives of the talk today are to talk about the concept of laboratory test misutilization, identify barriers and facilitators in reducing lab test overutilization, and then developing an approach to rational lab test selection. So why are we talking about this in the first place? Well, the reason we're talking about this is because there is an increase in both the cost per service as well as the number of services per person that we're providing in the past decade nationally. So we're doing more tests, we're doing more medications, we're doing more diagnostics. And as we're starting to do more, the question of appropriateness is coming around where we think about, well, is what we're doing actually helping patients and improving the care of patients? And when it comes to lab tests, it's about thinking about whether these tests are actually advancing the care of these patients. And unfortunately, even though we're doing more, when we start to look at the data on whether or not these tests are appropriate, what we see is that somewhere between 16 to 56% of lab testing is considered to be inappropriate. So how does misutilization occur? And misutilization can really be both overutilization and underutilization. So when we're ordering a test for diagnostic reasons, where we're trying to rule in or rule out a diagnosis, sometimes misutilization can occur when we use a shotgun approach. And a shotgun approach is when we try to order the entire panel of tests for all possibilities that we might think about. And in that case, you're probably ordering more tests than necessary. It can also happen when we're monitoring a condition. So sometimes we order a test to monitor drug levels, and all those guidelines do exist for some of these things. Sometimes there is a risk of repeating the test too often or not often enough. And as you will have heard earlier, screening particularly is an area which is a high risk of overutilization, where tests are often done inappropriately and done outside of guideline and evidence-based recommendations. And why overtesting is important is because when we overuse lab tests, we actually increase the rate of false positive results. So what we sometimes see is that we're ordering way more tests, but just by chance alone, we're going to see some of these tests turn out to be positive. Sometimes this is leading to overdiagnosis, more further tests, overtreatment, and then a downstream cascade of patient harm and health system costs related to this. So let's dive a little bit deeper into overutilization. So I generally think of them in three sort of broad categories. Tests can be overutilized when we use a shotgun diagnostic approach. And this is when we use exhaustive order panels. And this is because there's a lot of time constraints for clinicians and knowledge barriers which prevent us from predicting the probability of disease of a particular disease for the patient in front of us. And how we might be able to move away from that, again, at a systems level, is to think about evidence-based, stepwise ordering algorithms that facilitate rational ordering, and in the future, hopefully, more decision support tools to estimate probability of disease at the time of order entry. Another category of overutilization is in the area of redundant testing. So redundant testing occurs when tests are ordered just because people weren't aware that they were already ordered in the recent past. And this occurs because of disconnected electronic health records, lack of access to integrated records. Redundant testing can also occur because there may be a lack of knowledge and appropriate repeat time intervals. People may not be sure on when we expect to see a change in a test, and it's ordered more frequently than that. And how we might move away from that is thinking about integrated electronic health records, and also to have policies to avoid repeats within a particular time interval, of course, with an override option for clinical exceptions. And then another area where overutilization persists is in the area of specialized and novel tests. So these are tests that are not used very often, and there's often knowledge barriers in understanding how or when these tests need to be ordered and how they need to be interpreted. And this can often happen because there's lack of access to timely knowledge or specialist support in ordering these tests. And facilitators for that is looking at focused education and decision support with order entry. This is kind of a high level way of thinking about the different areas of overutilization. But the question that we always ask is, well, what can I do differently in my practice? So what we're going to do now is work through a couple of case examples and see what are some pearls that we can incorporate into our own practice to help improve the value of lab test utilization and also improve the value of our time. So we'll begin with the case example. So you're assessing a healthy 25-year-old female in your clinic for her first antenatal appointment. She asks you about being screened for thyroid disease in her pregnancy. What is your answer? So you'll find out as you start looking through the data and guidelines here is the universal screening in pregnancy for subclinical hypothyroidism is actually no longer recommended by the BCG PEG guidelines. If a woman is pregnant or planning pregnancy, TSH testing is indicated if there are certain specific risk factors that put them at risk for thyroid disease. In fact, harm could occur if a pregnant patient is overtreated. So these BC guidelines are consistent with the Canadian Task Force and Screening Guidelines that came out in 2019. And where's the evidence for this? Well, a meta-analysis of 3 randomized controlled trials in women with subclinical hypothyroidism diagnosed in pregnancy found no evidence of benefit of levothyroxine therapy on obstetrical, neonatal, childhood, or neurodevelopmental outcomes. In fact, current practice patterns contribute to overdiagnosis of hypothyroidism and overtreatment in pregnancy, and that is actually associated with harm in the form of preterm delivery. So what is the first clinical pearl in this case is use lab test guidelines when available. So this particular patient who does not have specific risk factors for thyroid disease should never be screened in the first place, because then you avoid the downstream cascade of what do you do with this TSH value? Does there need more testing? Should they be on levothyroxine or not? So we'll continue with this case example. So fast forward 10 years. The same patient is now 35 years old, and she's coming to you with symptoms of fatigue, weight gain, coarse and dry skin, cold intolerance, and amenorrhea. Now, prior to coming to your office, she's done some workup already through another physician that she found and was easy to access online. So as you think about what you would do with this case, one of the things I wanted to mention is that it's very common to have repeat laboratory test orders on the same patient. And unfortunately, that happens because their healthcare system is structured in a way that often there are multiple care providers for the same patient. And something that's very useful, I find, is to check Care Connect when possible or have integrated clinical EMRs to look to see what's already been ordered or what was recently ordered in your patient. Something that I've been doing more recently and actually I found very helpful is empowering patients to be engaged in their own testing results. And I will often have patients who are interested and engaged have their results on the phone with me during my appointment so they can show me the results as well. So the patient knows what was already ordered, and it saves me time in terms of logging in because they have it pulled up on their phone and I can just share with them and see what the results are. So again, the practice pearl here is use the technology that is available to us, recognizing there's always going to be holes and flaws and we don't have a perfect system set up, but use Care Connect when possible, use the patient access to lab results and orders when possible to avoid redundant testing. So in this particular case, you look up Care Connect and you see that she hasn't really had a thyroid testing done and you're suspecting hypothyroidism in this patient based on her symptoms. Then you start thinking about, well, what test do I need to order on her to check for her thyroid function? Well, here I present the beautiful algorithm actually laid out by the BCG PEG guidelines, which I'm sure you've seen before as well. So first, you actually start with the thyroid stimulating hormone, and that's it, the TSH test. The beauty of this is if you say hypothyroidism suspected, and it's abnormal, the lab will automatically then move to the second stage, which is checking for free T4, free thyroid hormone. And if you see hyperthyroidism suspected and the TSH is in that range, then they will actually do the free T4 automatically as well. And if it's the normal TSH level, then you stop there. So the nice thing about the stepwise algorithm is that you're not doing the whole panel of thyroid function, free hormones, as well as antibodies all at the same time, which is often really difficult to interpret when you get all of them at the same time, and it's hard to know what to make of it. You start with the TSH, and then you only move to the second hormones, or the next step of hormones if it's abnormal. Now, the good thing here is that, one thing that's really important to notice is that you don't even do the free hormones simultaneously. So you actually only start with the free T4. And there's very limited indications for when you would do free T3, which is if you're suspecting hyperthyroidism, the TSH is suppressed, but for the free T4, for some reason, it's normal. Then doing a free T3 and documenting the free T3 helps you with the diagnosis. So really it's very narrow indication for why you should need to do a free T3 in the first place. So the practice pearl here is use of stepwise testing over order panel testing. You will actually save yourself a lot of time and a lot of effort in trying to interpret what happens if the TSH is normal, but the free T4 is high and free T3 is low. You kind of avoid all of these different conundrums when you stick with stepwise testing, and you know exactly why you're ordering the next test. So in this particular patient, you order their TSH, it is high, the free T4 is done, it's low, you've diagnosed hypothyroidism, and you initiate appropriate pharmacotherapy. When would you now recheck the TSH for monitoring? Again, it's really important to think about the reference interval for when you should consider, when you would expect to see a change in this hormone level to know whether your dosing is appropriate or not. So if we go back into the nice algorithm that's there, you see over here, once hypothyroidism is confirmed and if you've initiated treatment, you monitor a TSH and you wait 6 weeks after start of treatment or change in dosage before retesting TSH. I think this is really important to know because I've seen, particularly in my practice, where so many times the TSH is ordered in a much shorter amount of time, which then leads to increases in dose because you thought that the dose was not appropriate. Another important thing to remember is that we only monitor the TSH. We don't monitor the free T4 or the free T3 because they can be quite variable and they don't actually represent any form of steady state in these patients. So you really want to be monitoring the TSH and waiting 6 weeks before you initiate therapy in this patient. So the next practice pearl is consider retesting intervals for individual laboratory tests. Again, if you don't order it too quickly, there's one less test you have to review. There's one less possible abnormal result that you have to worry about what to do about. So now this patient is on therapy with levothyroxine. She's feeling better. But now she says she's been reading around thyroid conditions and she wonders if she requires additional tests for her thyroid, including her antibodies checked. And then what do you think about that? Well, let's have a quick review of the different thyroid antibodies. So the one that you obviously would be ordering more or be more familiar with is the thyroid peroxidase antibodies or the TPO antibodies. This is used for diagnosis of Hashimoto's thyroiditis in a patient with hypothyroidism. An important thing here is the serial measurements are not indicated. The TSH receptor antibodies are actually used for diagnosis of Graves' disease in a patient with established hyperthyroidism. So most certainly, you would need to be doing that in this patient. And the thyroglobulin or the antithyroglobulin antibodies are actually tumor markers for patients who have undergone treatment for papillary or follicular thyroid carcinoma. So in general, for patients, when you're working them up for autoimmune thyroid condition, this is not an antibody that we need to be using at all. So thinking about this patient, I would say MTTPO measurement is not routinely indicated in patients with hypothyroidism because it doesn't really change clinical management. So outside of a few specific nuanced conditions, it's not really routine for most endocrinologists to even order the MTTPO antibodies. If you have ordered it once, repeat analysis is really not indicated. And again, for monitoring patients with hypothyroidism, just the TSH is sufficient. So for this particular patient, I would tell her that you don't really need to check any of these antibodies. It wouldn't change your care, and just monitoring the TSH is sufficient. So the practice pearl here is that it helps to know what your specialized test is or ask a friend. Because again, it takes a little bit of time up front to know what these specialized tests are, but it then does avoid ordering a lot of unnecessary tests and having to deal with the interpretation of these test results. So here's a summary slide of the different clinical practice pearls. So use lab test guidelines when they're available, because if you can just avoid ordering certain tests, it just helps prevent that downstream cascade. Avoid redundant testing. So harness whatever EMR power that you have, as well as patient engagement, to prevent ordering tests that have already been ordered. Use the stepwise testing over order panel testing, thinking about the most high value tests to begin with, and then sort of going over the second few tests as opposed to doing order panel testing. Consider retesting intervals for individual laboratory tests. So think about when you might expect to see a change before you order it again. And again, know your specialized test, look it up or ask a friend. It always takes a little bit more time up front, but will save you a considerable amount of time down the road. So we'll just let's try to apply these pearls to another example, which is vitamin B12 and folate testing. So first pearl, use lab test guidelines when they're available. So if you Google this, you'll actually find that there's BC guidelines on B12 and folate testing as well. And in fact, routine screening and testing is not evidence-based in asymptomatic individuals for B12, and folate testing is rarely indicated. So again, it helps to know that, okay, this is not a test that I need to be routinely screening for and testing. Avoid redundant testing, again, similar principles, harnessing existing EMR resources, using patient engagement. Use the stepwise testing instead of order panel testing. So there's again, you don't have to know the details, but there is a stepwise algorithm in the BC guidelines that start with B12 only. So you don't have to start with B12 and antiparallel cell antibody and homocysteine and methylmalonic acid. You start with one test, and then based on the results, you would go and do subsequent tests if necessary. Consider retesting intervals for individual tests. So applying this to B12, for B12, repeat testing should be at least 2 months after therapy has started. So again, this is a test where you don't want to be repeating it too quickly after starting therapy. And then know your specialized test, and particularly in BC, the indications for MMA and homocysteine is basically not done, is typically not needed unless very specific nuanced clinical situations. So with that, I'm happy to take any questions.
Anshula, thank you so much. Wonderful presentation, very clean and precise and practical. So I really appreciate that. We have a few questions. It says the disparate parts of our fragmented healthcare system connect through the patient. Basically saying that getting the patients engaged in this is another useful measure to improve health literacy. So.
Yeah, I completely agree. Thank you. That's a hugely important point. While we wait for governments to make that beautiful one province EMR system, in the interim, patients can be and should be advocates for their own safety.
Fantastic. Another question: what is your advice for responding to patients who present and ask to get their full thyroid panel? Something that I've seen typically promoted by naturopaths.
Yeah, it's a great question. So I do use patient educational tools for that. So I will walk them through why I'm not ordering these tests. It works for most of the patients. I think we just need sometimes our time to explain to them. It's not because I'm saving money or because you're not important as a patient to me. It's because this is my rationale for not ordering it. And I have now developed some of these standardized templates that I can use and share with my patients so they can ask more questions around it. There's always a small minority of people who will not accept that. And then I encourage them to follow up with their naturopaths around that. But I always try to explain why I don't order that. And that's what I do.
And Shula, those educational materials, are they available to others, and where would they find them?
Well, it's a great question, because as part of one of the projects that we're doing with the TI, we're trying to develop getting patient partners review this material, and we're hoping to be able to share it over the next few months through the TI as well. So it will be hopefully accessible.
Okay, great. Thank you. So for those in the audience, keep your eyes peeled on the TI website in the near future that you'll have access to some of those. The next question, does the stepwise strategy for lab testing TSH, T4, T3 might result in inconvenient delay, or does it remain compatible with clinical practice, especially for potential treatment of hyperthyroidism?
Yeah, it's a really great question. So the stepwise algorithm, if you say suspected hyperthyroidism or hypothyroidism, the lab automatically does the reflex test. So it's actually quick. But the problem is if you don't say that, sometimes you have to then do the subsequent test. So I always encourage people to use the suspected hypothyroidism. Now in the hospital, sometimes I have had these really unique cases where they're coming in what I suspect is severe hyperthyroidism or a thyroid storm, in which case I will call the lab and make the exception of saying, I just need the free T4 right away to know what I'm treating. And so there's always ways of just calling the lab for those rare cases, but I think it works really well for the vast majority of outpatients.
Okay, thank you. A comment saying that it's good to be reminded that symptoms, getting a good history, appropriate exam, and thinking about differentials leads to better and usually less testing. A question, are medications that inhibit vitamin B12 absorption like PPIs and metformin enough of a reason to check B12, or would you wait for symptoms?
That's actually an excellent question. So what the most recent BC guidelines say is that if people have risk factors like the ones you mentioned for B12 deficiency, and you have suspicion for clinical symptoms, they actually recommend treatment because the actual assay for B12 is not very good, and it's very hard to correlate the B12 levels with deficiency. So if somebody has risk factors and you say things like you're seeing cognition, you're seeing neuropathic changes, you're seeing macrocytic anemia, it's easier and better just to start them on treatment.
Okay. As a family practitioner, I often see recurrent panels of tests included to the ones that are not covered by MSP, ordered by weight management clinics. Not sure how to interfere with the ordering of other providers and consultants. So any advice that you have?
Yeah, that's a question. I actually feel like what you're doing right now is not getting in. Like I don't sign off my name on these tests that I don't agree with and I don't want to follow up with. So if somebody wants to order these tests separately, privately, I encourage them to follow with that provider that's doing it. I think the answer to that is a more systemic level thing, and that's where we are working with the TI and the PHSA at a provincial level to see how testing and stuff should be managed, particularly when there's not as much evidence for these tests. So I think there's going to be more systemic solutions needed for that. But as an individual practitioner, I just try to keep my name off of those tests that I don't want to order and I don't want to interpret.
Okay. Do you have any advice for what to do when patients arrive with a panel that was recommended by a naturopath?
Yes.
You have no idea what to do with the results.
Yes, it is a very, very common thing I see in my practice. And the same thing, which is why I've developed this educational material. I provide them with, this is the reason why I don't order these tests. This is the guidelines and why I don't order them. And I sort of do exchange that. And I find I can convince the vast majority of patients as to why it's not necessary. And for the small few that still want it, I encourage them to continue follow with their naturopath.
Okay, thank you. What about B12 screening for South Asians? Should it be routine? How often? Not at all?
Yeah, so same thing, because the B12 test is actually not very good and predict, like the levels don't actually correlate with symptoms. If patients with if there's risk factor groups with B12 deficiency, if they're vegan, if they have other kind of risk factors for that, recommend supplementation with B12.
Is there is there some way that the lab can take some responsibility for not doing tests that aren't reasonable or are redundant? So is there an accountability structure for labs?
No, unfortunately not. But those are things that we are trying to work more systemically with the TI.
Okay. What's the line between antibiotic conservation and lab test conservation? I'm not sure what the question's getting at, but do you want to comment?
I mean, the one thing I think about is that they are related, right? One leads to the other. The one common thing I see in hospitals is blood culture is ordered on everyone. And then inevitably, there's always a few contaminant blood culture patients, and they always get vancomycin, at least a couple of doses before you got confirmation that the gram-positive cocci was actually a contaminant. So where I see is if you were very careful about who you ordered the blood cultures on, you'd see less likely the vancomycin doses as well as the risk factors or the adverse events associated with vancomycin. Kind
Okay.
of one goes with the other.
Okay. There's a request to share the educational tools, and as Anshula mentioned, within in the near future, hopefully they'll be posted, and we'll alert you if you've subscribed to the Therapeutics Initiative service, then you'll be alerted to that as well. Another question, what tests might be appropriate for general fatigue in primary care without specific clues on history and physical?
Yeah, so great question. It's going to be a presentation by itself, but my general practice is if I have no leading clues on history and physical, and it is that I don't actually order a test. For me, it's a lot of reassurance and follow up, and saying it doesn't look like there's any red risk factors. And often I'm seeing them after the family doctor's already done a good review and thorough kind of testing. So when I see them, it's very common for me to not order any more tests and just spend a lot of time explaining to them why I feel reassured, why I feel like we've ruled out the big bad things, and why we'll stay in touch and follow up in a few months to make sure things are staying on track for them.
Thank you for that. Another benefit of testing, this is a comment, another benefit of rational testing is decreased carbon footprint of our investigation. So very good point there. You know, Galen also mentioned the soft costs, and I don't know if this is so soft, but it's those other things or impacts on the system that we need to consider. So excellent point. There's several questions, and so it's going to be rapid fire, Anshula. Usually guidelines are 10 years behind recent evidence. T3 is one of that is an available hormone. Normal T3 can produce symptoms with the resistance to T3 receptors. TCH being normal in this situation, and treating numbers versus treating symptoms, especially surrogate levels of TSH. Any thoughts or comments on that?
Yeah, so it is true that the evidence is evolving in this area. So the guidelines are most up to date with respect to these guidelines that have been updated recently. So they are most up to date with the evidence that we have. There's always going to be specific patient populations where things don't vary, and they're a very, very small percentage of the population where you have to consider advanced testing. But I really think in that, if you're concerned about that, it is best to then refer on to an endocrinologist or somebody who deals with these patients, because it becomes very difficult, even as a general internist, to then try to interpret these results and see if they apply to the patient.
Okay. There's a question about the recording of all the presentations today, which I'll get to in the closing remarks. So I do see that, and I'll get to it. Regarding B12, are you talking about replacement or maintenance dosing?
So if you're suspecting symptoms of B12 deficiency, it would be replacement. But if you're concerned that they might develop B12 deficiency, you can consider maintenance.
Okay. And I think you answered this earlier, but many patients come with vague symptoms like fatigue with no specific physical findings. Are there specific guidelines? So you've gone through that. At what point do we order CNS on every suspected wound, infection, UTI versus treating with what we suspect is the best antibiotic without knowing for sure what bug we are treating?
Yeah, that's a good question. It depends to a large extent on what you think might be the resistance pattern for the particular patient that you're seeing. If I work at St. Paul's Hospital downtown Vancouver, so I see a lot of people who have had multiple wounds and multiple hospitalized admissions. So they're very high risk for having resistant pathogens. So where possible, if possible, I try to obtain wound cultures, so I can actually narrow down my antibiotics, because they often get started on broad spectrum antibiotics. So it helps me in that way. If I was seeing somebody in the outpatient world and I was quite concerned quite reassured that it's most likely community acquired, I think empiric antibiotics and watching and waiting for resolution of symptoms is probably a reasonable approach.
Okay, thank you, Anshula. And one last question for you, and then Tom, if you're still around, there's one question I believe you wish to answer live. So for you, Anshula, can you comment on increased testing for H. pylori?
Yes, I can comment on that more from clinical practice, and this is something I wanted to do more of an evidence dive. So we've been testing a lot for H. pylori because of a lot of non-specific symptoms of gastritis and so on. And for patients admitted to hospital, with nearly everybody who has an ulcer is getting sent for H. pylori serology. Increasingly, I've noticed that people are being put on therapy for H. pylori outside of testing, where you feel like, well, a test may not be sensitive enough. And if they've already developed an ulcer, I'm just going to treat them for H. pylori and then watch their symptoms. So I haven't looked at the data or the evidence to see the cost effectiveness of the two strategies, but I have noticed that amongst gastroenterologists where they're increasingly recommending to just treat and to see and then test for cure after, rather than testing for H. pylori upfront.
Okay, thank you for that. Once again, Anshula, thank you so much. Wonderful presentation. You answered so many questions. We really appreciate it.
Thank you.